Good morning to everyone. Hi, viewers and my dear students. Hope all are healthy, fine, and you are ready for our online class. And welcome you all in our channel rgcsk.edu. Today we will see nursing subject uh, from the midwifery and obstetrical nursing. So it is one of the obstetrical emergency condition, and this will be benefited for all our nursing students. The condition is postpartum hemorrhage. So today in our live class, we will discuss about what is meant by postpartum hemorrhage, what are the causes of postpartum hemorrhage, what are the types of postpartum hemorrhage, and investigation, clinical manifestation, and what is the management and role of nurse in prevention of postpartum hemorrhage. So this during an obstetrical emergency, it is a multidisciplinary approach, and as a team we have to work to reduce the maternal mortality and morbidity rate. So postpartum hemorrhage. First we'll see about the introduction of postpartum hemorrhage. Postpartum hemorrhage, it is one of the third stage complication. So you know what is meant by labor. Labor, it is a series of events that takes place in the genital tract in an effort to expel the viable product of conception from womb to the external world. In the labor, generally we can tell 4 stages are there. First stage is known as cervical stage. This will start from initiation of onset of spontaneous uterine contraction till the cervical dilatation. Then second stage of labor, in the cervical dilatation, complete cervical dilatation. The second stage of labor starts from complete cervical dilatation till the delivery of the fetus. And third stage of labor. Third stage of labor, that is, the period starts after the delivery of the fetus till the complete delivery of the placenta and the membranes. So in this third stage of labor, if the woman having bleeding or hemorrhage, then we can tell it as a postpartum hemorrhage. Postpartum hemorrhage, it is a life-threatening obstetrical emergency situation. So as a nurse or midwife, we have to be a good prompt role in order to identify what is postpartum hemorrhage, what type of postpartum hemorrhage, what are the clinical features that goes for shock or even for the maternal death, and we have to give a emergency care to save the life of the woman. Let us see what is the meaning of postpartum hemorrhage. Postpartum hemorrhage, any bleeding that happens during third stage of labor, more than 500 ml of blood loss, then we can tell it as a postpartum hemorrhage. This was given by WHO. Or any bleeding that happens from the genital tract or into the genital tract after the delivery of the fetus, and this will deleteriously affect the general condition of the women, such as increased pulse rate, drop of the BP, and shock symptoms. Then we can tell this blood loss as postpartum hemorrhage. So what the definition says that after the delivery, anytime if the woman is having bleeding, that is before the expulsion of placenta or along with the expulsion of the placenta or after the expulsion of the placenta till the puerperium period, any period if the woman is getting bleeding, then we can tell it as a postpartum hemorrhage. Once again, I will repeat the definition. Postpartum hemorrhage, it is the bleeding that happens from the genital tract or into the genital tract anytime after the delivery of the fetus till the puerperium period, and the condition of general condition of the women is deleteriously affect, such as increased pulse rate or dropping of the BP. So this we can tell it as a postpartum hemorrhage. Or simply we can tell us in a vaginal delivery, if the blood loss is more than 500 ml, or in the cesarean delivery, if the blood loss is more than 1000 ml, or in the cesarean hysterectomy, if the blood loss is more than 1500 to 2000 ml, then we can tell it as a postpartum hemorrhage. So average blood loss during the normal vaginal delivery is 250 to 300 ml. So maximum 500 ml. If the blood loss is more than 500 ml in a normal vaginal delivery, then we can tell the condition as postpartum hemorrhage. So this condition we have to seriously take action in order to save the mother. Next we will see about what is the incidence. Incidence worldwide, 14 million women are affected with postpartum hemorrhage. And 2 to 6% of all the delivery cases we can see the postpartum hemorrhage. This postpartum hemorrhage is one of the major reasons for maternal death. 24% of maternal death is due to hemorrhagic condition that happened during pregnancy or in the labor. So after the delivery of the fetus, due to postpartum hemorrhage, we can able to find out the maternal death. Now we have the prevention such as active management of third stage of labor, safe motherhood initiative, proper antenatal care to prevent the high risk labor. So these somewhat we can manage the postpartum hemorrhage. As a nurses, we should have a good observation skill during the labor, mainly in the third stage of labor, to monitor how much blood loss the woman has and what severity the woman is going for postpartum hemorrhage. Next, we will see what are the types of postpartum hemorrhage. According to the blood loss, the postpartum hemorrhage can be divided into three. That is minor postpartum hemorrhage. When the blood loss is less than 1000 ml, then we can tell as minor postpartum hemorrhage. Then it is major postpartum hemorrhage. When the blood loss is more than 1000 ml, then we can tell it as a major postpartum hemorrhage. Then one is severe. Another type is severe postpartum hemorrhage. When the blood loss is more than 2000 ml, then we can tell it as a severe postpartum hemorrhage. The mother, anytime the mother can go for maternal death. Closely 24 hours we have to monitor the mother in order to save the mother to come back to their normal life. Next, we will see what are the clinical type of postpartum hemorrhage. Clinically, we can divide the postpartum hemorrhage into two types. One is primary postpartum hemorrhage and another one is secondary postpartum hemorrhage. In the primary postpartum hemorrhage, the hemorrhage that takes place immediately after the childbirth within 24 hours of duration, then we can tell it as primary postpartum hemorrhage. So here what it explained means, after the delivery of the fetus, with the if any hemorrhage that takes place within 24 hours, then we can tell it as a primary postpartum hemorrhage. The next one is secondary postpartum hemorrhage. Secondary postpartum hemorrhage, the bleeding that takes place during the third stage of labor, that is after 24 weeks till the puerperium period, anytime during the puerperium period, that is within the 6 weeks. So immediately after the delivery of the child, within after 24 weeks, 24 hours or till the 6 weeks duration, anytime the woman is getting bleeding from the genital tract, then we can tell it as a secondary type of postpartum hemorrhage. So first we will see about primary type of postpartum hemorrhage. Primary, I told, the bleeding that takes place within 24 hours of childbirth. So here this primary postpartum hemorrhage we can classify it into two types. First one is third stage postpartum hemorrhage. Second one is true postpartum hemorrhage. Third stage postpartum hemorrhage. So the bleeding that takes place into the genital tract before the expulsion of placenta, then it is known as the third stage postpartum hemorrhage. Another type of classification is true postpartum hemorrhage. The bleeding that takes place into the genital tract subsequent or along with the expulsion of the placenta, then it is known as the third stage postpartum hemorrhage. So I hope you understood about the types of postpartum hemorrhage. It is divided into two types, primary postpartum hemorrhage and secondary postpartum hemorrhage. Primary postpartum hemorrhage, the bleeding that takes place into the genital tract within 24 hours of childbirth. This can be classified into two types, third stage postpartum hemorrhage, that is bleeding that enter into the genital tract before the expulsion of placenta. Then another one is true postpartum hemorrhage. That is the bleeding that takes place subsequent or along with the expulsion of the placenta. These two bleeding takes place within 24 hours. Then second one is secondary type of postpartum hemorrhage. That is the bleeding takes place after the childbirth, that is after 24 hours or any time during the puerperal period, that is within 6 weeks of duration. That is known as secondary postpartum hemorrhage. Then we will let us discuss what are the causes of postpartum hemorrhage. So causes of postpartum hemorrhage, you can remember mainly 4 T's are there. 4 T's you can remember. First one is tonicity of the uterus. And second one is tissues. And third one is trauma. And fourth one is thrombin. So these are the 4 T's you can remember the causes of postpartum hemorrhage. So first we will discuss the first T, tonicity of the uterus. So main causes of postpartum hemorrhage is atonicity of the uterus. So in the third stage of labor, after the delivery of the fetus, the uterus will be contracted in order to separate the placenta from the spongy layer of the decidia. So here the uterus muscle becomes retracted and it will form like a living ligature, and this will separate the placenta. If the uterus is not able to contract it, then the uterus becomes so much of relaxed. It becomes soft, flabby and boggy in nature. So that is known as the atonicity of the uterus, loss of tone. That is known as atonicity of the uterus. So let us discuss what are the causes of atonicity of the uterus. So normally what should happen after delivery of the child? The uterus become hard. If the uterus is not become hard, if it is become soft, flabby or boggy, then it is known as the atonicity of the uterus. So we will see what are the causes of atonicity of the uterus. Main causes of atonicity are, first one is grand multipara. If the women have so many childbirth, the uterus during the third stage of labor leads to less contracted or loss of contraction or retraction of the muscle fibers leads to postpartum hemorrhage. Second cause is over distension of the uterus. Over distension of the uterus. The reason for the over distension of the uterus are multiple pregnancy. If the women have more than one fetus, polyhydramnios conditions, the uterus become over distended, and during the third stage of labor, the uterus cannot be, the muscle fibers cannot be retracted or contraction cannot be achieved. As a result, PPH can be happen. Then next cause we can see malnutrition and anemia. Malnutrition and anemia, they have the loss of blood. Even a slight leads to less than 10% of hemoglobin. This leads to severe complication of PPH. And another one is if the woman have during the labor any obstructed labor or precipitate labor. Precipitate labor, very fast delivery. The first and second stage of labor duration will be less than 3 hours or 2 to 3 hours between the labor will be completed. That is known as the precipitate labor. And if they are having any use of anesthetic agents, this also can lead to postpartum hemorrhage. And if they have use of drug of oxytocin for augmentation of labor or induction of the labor, if the oxytocin is stopped, the oxytocin has to be continued after the delivery of the child. This has to be act as an active management of labor. So that also can lead to postpartum hemorrhage. Then next one is mismanagement of third stage of labor. As a nurses or the midwife, when we are conducting the delivery, we have to be very much patient enough to conduct the delivery of the placenta. So vigorously we are doing fundal pressure or pulling of the cord or needling in the uterus. This can lead to postpartum hemorrhage. So any mismanagement of third stage of labor. And causes such as if the women have obesity, more than 35 BMI is there, if the age is more than 40, if they already have any intake of tocolytic agents like ritrodin, so the uterine muscles already it is relaxed, that doesn't have any contraction. And another condition is morbid adherent placenta. This is one of the placental abnormalities. The placenta is tightly or morbidly adherent to the uterine muscle layers, like for placenta accreta or increta. So like that conditions. So these are the major causes for getting atonicity of the uterus. So first, as a nurse, we should know what is the cause for getting this flabby or boggy or soft uterus immediately after the childbirth. So next T, first T we discussed about tonicity, that is the atonicity of the uterus. Second T that indicate the tissues. Any tissues that is present inside the uterine cavity, tissues of placental bits or fetal tissues that is present inside the uterine cavity, the woman can happen postpartum hemorrhage. So we have to explore and see what type of tissues is present in the uterine cavity. Then next one is trauma. Any injury in the genital tract during the vaginal delivery or the operative, that is cesarean section. So any injury to the perineum, vagina or cervix or internal structures of uterus. So this genital tract injury can also leads to vaginal bleeding, and we can assess from the episiotomy any bleeding is coming. So when we are doing episiotomy, an operative procedure to enlarge the vaginal orifice to deliver the fetus. So during this time, if the women have excessive blood loss, that also comes under the trauma. So these are the causes that comes under the trauma, such as perineal tear, episiotomy, bleedings. The next one is trauma to the cervix, vagina or perineum, and uterine rupture or uterine trauma. The last one is thrombin, coagulopathy disorders if the women have. The women have the features of increased fibrinolytic activities or coagulation factors problems the women have after the delivery. This thrombin, some of the conditions during labor, the thrombin status can be affected. So what are the conditions like? If the mother have abruptia placenta, so we can see this cause for atonicity of the uterus also, APH. APH, that is known as antepartum hemorrhage. Antepartum hemorrhage consists of two conditions are there. One is placenta previa and another one is abruptia placenta. These both are bleeding disorder. These both cases leads to atonicity of uterus also. Here in thrombin, what happened? In abruptia placenta. Abruptia placenta is nothing but it is the premature separation of placenta, and the blood will be accumulated in between the placental and the uterine wall. So what happened here? Sometimes revealed type of bleeding is there or concealed type of bleeding. When there is having a concealed type of bleeding, so uteroplacental apoplexy complications can be happen. That is known as cobiliar uterus. So during this cobiliar uterus, coagulopathy problem will be happening and postpartum hemorrhage can happen. And another condition is preeclampsia. If the women have toxemia, that is after 20th week of gestation, it is a multi-system disorder characterized by increased BP 140 by 90 mmHg, proteinuria with or without edema in a previously normotensive woman. That is known as the preeclampsia. So when the preeclampsia, they are getting any complication such as HELLP syndrome, hemolysis, elevated liver enzyme, and low platelet count. So this problem can lead to coagulation status can be affected, and because of this cause for getting the postpartum hemorrhage. So these are the causes for getting postpartum hemorrhage. So we have discussed about 4 T's. First, we have discussed about causes of atonicity of the uterus. Then next, we have discussed about causes for tissues or the fragments that is present inside the uterine cavity. Then next, causes of the trauma, any injury to the genital tract, and last one is causes of the thrombin. So you can remember 4 T's are the major causes for getting the postpartum hemorrhage. Next, we will discuss about what is the clinical manifestation. Clinical manifestation, according to the blood loss, revealed type of blood loss, the woman will have the signs or symptoms. It's mainly signs we can elicit. The women have vaginal bleeding. So more than use of more than vaginal pads or vaginal cloths, sanitary cloths, what we are using, that will be pooling with the blood, sudden rush of blood, and this will be covered by all the area of the sanitary pad. So like that we can visualize. Sometimes the blood will be overflowing from the bed and it will be spilling to the floor. According to the loss of the blood, we can categorize whether it is less than 30 ml, less than 100 ml, or more than 500 ml, 1000 ml, or 1500 ml. If the blood is bleeding happens and it is spilled from the blood into the floor, then we can tell it as it is more than 1500 to 2000 ml of blood loss is there. So when we are assessing the blood loss, women have the features of shock will be there. Shock like increased palpitation will be there. The women pulse rate will be increased, and the women we have to check the BP. BP will be dropping, decreased BP, that is known as the hypotension. And women cold, clammy skins will be there, extremities, and pallor can be seen in the eyes, tongues, or all over body. Pallor can be identified, and these are the major. And suddenly collapse can happen, even maternal death can happen. So these are the major clinical symptoms, and such as dyspnea, sweatings. So these are the problems we can identify from postpartum hemorrhage. Next, we'll see what is the investigations. Investigations, mainly we have to assess what is the nature of the woman, how much blood loss is there, and we have to monitor the BP, and we have to assess the shock symptoms, and we have to take the blood to identify what is the blood group, what is the hemoglobin, hematocrit value. This hemoglobin, hematocrit, all will be less than 10%, and liver enzyme. We have to assess liver function test, kidney function test has to be assessed to note out any what is the kidney function, what is the liver function, that all we have to assess it. Next one is what is the management. Management, according to the condition of the PPH, we can give the management. Whether what is the type of the PPH we have to assess, whether it is a primary PPH or whether it is the secondary PPH. Primary PPH, first one is we can see it is divided into two: third stage PPH and true PPH. Third stage PPH, that is the bleeding that takes place into the genital tract before the expulsion of the placenta. So our main aim, we have to see whether the placenta is expelled, what is the blood loss, restoration of the fluid and blood volume, and stabilize the mother and minimize the bleeding. That is the aim in giving the management of true management of third stage postpartum hemorrhage. So first step, we have to do the fundal massage has to be done. So with our the two hands, we have to give a fundal massage, and next we can catheterize the bladder and continuously. Then we can give the medications. Medication, mainly we can give oxytocin, 10 units IM can be given, or we can give the methergine, 0.2 mg methergine can be given, IV or IM. Then we have to assess and monitor the mother, and we have to see the placenta have separated or not. If the placenta is separated, we can remove the placenta. If the placenta is not separated, we can go with a controlled contraction or fundal pressure. In the controlled contraction, we can use both hands. Dominant hand can be placed on the umbilical cord. Non-dominant hand can be placed on the abdomen, and steady traction, that is pulling actions, can be given on the dominant hand, and we can give a push, that is counter traction, on the abdomen, and we can pull the placenta and we can deliver the placenta. So this can be done by control contraction method of fundal pressure. If the placenta is delivered, then it is fine. If the placenta is not delivered, then we can go with the manual removal of the placenta under the anesthesia. So that can be done by the obstetrician. So the midwife nurse can assist the procedure. So the whole hand has to be placed inside the uterus, in between the placenta and the uterine layer. With a slicing movement, they can remove the placenta from the uterine layer, and the placenta can be separated and they can be delivered the placenta. That is manual removal of placenta. So this comes under the third stage management of postpartum hemorrhage. So here, if it is placental is not separated, like that they can do. And if they are having the traumatic type of injuries, identify what is the trauma, that can be repaired. The next management, that is mainly comes under the true postpartum hemorrhage, the bleeding that takes place along with the delivery of the placenta. So we have to see whether it is the atonicity of the uterus or whether it is the traumatic uterus. So here what happened, the placenta will be delivered, the mother will have the bleeding. So here mainly, so if it is an emergency condition, we have to go for calling the help for supporting staff, and we have to give information that the patient is of serious. Immediately after the delivery of the placenta, the bleeding is having, and we have to palpate and see the uterus, whether the uterus is flabby, soft or boggy, and we have to see the genital tract, vaginal examination. No other tear is there, cervical tear or vaginal tear, like that we have to find. So if it is an atonicity of the uterus, we have to call for the help, and we have to position the mother. Head and can be flattened, and foot and can be elevated, and we have to give large bore IV lines have to be start with the both hands, and injection oxytocin can be given IM 10 units, and IV oxytocin, that is 500 ml or 1 liter, that can be diffused with 10 units of oxytocin, and we can start as soon as fast for the women. 60 drops per minute can be kept, and this has to be monitored. So oxytocin can be IM also can be given along with the oxytocin. Infusions can be given with the normal saline, and fast crystalloids can be given. Catheterize the women. Next step is we have to give the oxygen. 6 to 8 liters of oxygen, maximum of 15 to 20 liters of oxygen according to the need of the patient. So this has to be done, and we have to withdraw the blood to send for identify the hematocrit, then RH factors and blood group, and cross matching, and we have to see for the liver function, renal functions. For that we have to immediately collect the blood and send for the lab to find out the what problem really the women have. So this as a team we have to do the work, and again we have to see how the bleeding is for the women, and we have to inform to the obstetrician. So if the women having continuous bleeding is there, first step we can give the fundal massage. So fundal massage, then we can administer the oxytocin or 0.2 mg of methergine, or catheterized, and we can stabilize the mother. The next step, we can do the examination under anesthesia, and we can give administration of medication such as injection, methyl, prostaglandin, even alpha, 200 μg every 15 minutes. So that can be administered. or we can give misoprostol 1000 mcg. Rectum they can be administered, or like oxytocin, drug of choice is there. Tranexamic acid, drug of choice is there. So and you have to see whether this is of due to tocolytic agents. That type of drug also can be given. So these are the drug management. The next step we have to see is third step is bimanual compression of uterus. Still the bleeding is not controlled, means we have to go with bimanual compression of uterus. In the bimanual compression of uterus, the dominant hand has to be closed like a fist, that is like a clenched hand, and this hand has to be placed inside the posterior part of the vagina. The non-dominant hand has to be placed on the abdomen. So the uterus has to be squeezed between the two hands. By the pressure, the bleeding can be controlled. So that is known as the bimanual uterine compression. External bimanual uterine compression or internal bimanual uterine compressions can be given. Then if the bleeding is not stopped, next step. What is the next step? Next step, tight intrauterine package. The uterine compression has to be given. In the tight intrauterine package, we can take gauze pieces, 15 meter of gauze pieces. We can roll the gauze pieces and we can put it in the antiseptic solution, and we can put inside the uterine cavity, fill the uterine cavity. No space has to be present. And again we can fill in the vaginal region also. So full the uterus and the vagina has to be packed with the gauze piece, and this can be placed for 24 hours. So this also will give us a compression for the uterus, and this will minimize the blood loss. Or balloon tamponade. So for the balloon tamponade, we can use Foley's catheter, condom catheter, or Beckery catheter. So this catheter can be inserted into the cervix, into the vagina, and the balloon can be inflated. So 100 to 200 ml of normal saline can be infused, and the balloon can be inflated. So this can be kept for 4 to 6 hours. So this will give a pressure on the uterus, and this will helps for minimize the blood loss. And anti-shock garments, non-pneumatic anti-shock garments are there. So through the referral services in the peripheries and all, they can use this garment, or in the hospital setup also they can use the garment in order to give a pressure on the arteries, and this can minimize the blood loss. And another one is aortic compression. External aortic compressions. So we can close the fist on the hand, and the obstetrician can be done the procedure. They have to give a direct pressure along the umbilical region. So this pressure has to be given into the spine, onto the aorta, and the pulsation of the femoral artery can be felt. So once the pulsation is stopped, they can feel that PPH can be reduced. So otherwise the pulsation is present, means there is no use of giving the aortic compression. Then next they can plan for the next step. Next step is they can decide for the surgical treatment or surgical management of postpartum hemorrhage. So these all management they have done, and still the bleeding is not controlled, means the next choice of treatment is surgical. In the surgical, they can give a tight intrauterine sutures, that is known as B-Lynch brace sutures, or multiple square sutures can be done on the uterus to control the bleeding by giving a compression by these sutures. Or next step is internal iliac artery ligation, ovarian artery ligations. So this ligations procedure can control the bleeding. Or arterial embolism procedures to reduces the bleeding. So this procedure can be done. If all this procedure has done, and they can see how much blood loss is there for the women, whether the blood loss has reduced or blood loss is there, means then they can decide they can go with the procedure of hysterectomy. Hysterectomy means removal of the uterus. So this is the end management for the atonicity of the uterus. So if they have the children, no problem. If they don't have the children, very carefully the obstetrician has to decide to remove the uterus. If all this management has done and still the bleeding is not controlled, means at the end the obstetrician can decide to remove the uterus. That is known as the hysterectomy. As a nurse, we can assist in the procedure. So these are the management and the surgical management that comes under the atonicity of the uterus. Then next one is traumatic uterus management, traumatic postpartum hemorrhage. In the traumatic postpartum hemorrhage, they have to identify what is the problem, whether it is a cervical tear or it is an uterine tear or the perineal or from the episiotomy wound. So they can identify and they can do the ligation or suturing, and they can reduces the traumatic bleeding. Next one is secondary postpartum hemorrhage. In the secondary postpartum hemorrhage, the bleeding that takes place in the genital tract after 24 hours of childbirth within puerperium period, that is 6 weeks. So they can get discharged or they can in the hospital itself. So they can have the bleeding. So the bleeding mainly due to the problem of any injuries or any infections or any problem in the genital tract, or due to the thrombin problems or tissue problems, this secondary hemorrhage has to be done. So when they come to the hospital, they have fouls, lochia will be there, bleeding from the genital tract will be there. So they have pyrexia, infectious conditions can be there. With the obstetrician can do the ultrasonography and they can find out what is the reason for getting the secondary postpartum hemorrhage. So the examination can be done under the anesthesia. If they want, they can do the surgical procedure and they can remove the placental, they can remove the tissues that is present in the uterus, or they can control the bleeding. So this is the main management comes under the secondary postpartum hemorrhage. So we have seen overall management. Next we can see what are the prevention. Prevention in the postpartum hemorrhage, very difficult to prevent the postpartum hemorrhage, because the postpartum hemorrhage happens during the delivery time, after the childbirth. So we cannot expect what is the major cause for getting the postpartum hemorrhage. So we have 4 T's are there. So based on that, we can give the management. Here what we have to do means prevention mainly focus to reduces the maternal mortality rate, morbidity and complication that happens due to postpartum hemorrhage. So we can start from the prevention activities from the antenatal period, then to the intranatal period. Antenatal period, we have to advise the women for preconception care and antenatal care. Antenatal preconception, they can take folic acid and iron. They can restore the hemoglobin, normal hemoglobin level in the body. Same like that, during the pregnancy also, they can take the regular iron tablet. If they have the anemia problem, that has to be treated, and their body has to be fit for entering into the labor process. So preconception care and antenatal care. And another one is, as a safe motherhood initiative, all the antenatal mothers, they have to register, and we have to monitor the high risk approach to find out which are the mothers are prone for getting high risk pregnancy and high risk labor. Whether the mother is having grand multipara, whether the mother is having multiple pregnancy, previous history of any abortion is there, present history of antepartum hemorrhage like placenta previa, abruptia placenta, any medical conditions, preeclampsia, they can have the HELLP syndrome, they can have the coagulation problem. So these mothers has to be giving a separate high risk pregnancy approach and pregnancy care that can limit the complications that happen during the labor. And next one is, we have to screen out the high risk mothers, and we have to give a proper drill practice for all the midwife who are dealing with the postpartum hemorrhage. In the hospital setting means we can have a drill practice how to take care of a postpartum mother during a hemorrhage, how to catheterized, how to give medications of oxytocin, how to administer the fluids, how to give misoprostol drug, how to identify the blood loss. So all this can be taught to the midwife in order to give a proper emergency care. Next, during the intranatal period. During the intranatal period, we have to see the how much blood loss is present in the mother. Close monitoring, that is partograph, has to be monitored in the early stage of labor to note out any obstructed labor is there, any precipitated labor is there, any malpresentation is there. And same like during the delivery of the placenta, we have to assess the how the blood loss is there, any shock symptom is there. So we have to avoid the mismanagement of third stage of labor. So we can follow the procedure of active management of third stage of labor. In the active management of third stage of labor, all the mothers can be given fundal massage after the delivery of the fetus or the delivery of the placenta. Fundal massage can be given, then oxytocin injections can be given, or misoprostol drug of choice can be given, that is known as uterotronic drugs. And use of controlled cord traction. Delivery the placenta by controlled cord tractions. After the delivery of the placenta, examine the placenta whether all the placenta has K mode. All the cotyledons is there, membranes are there, no placental bits or tissues is inside the uterus. That they have to monitor. If they are following the active management of third stage of labor, 40 to 60% of postpartum hemorrhage can be reduced. And as a nurses, we should don't do any negligence while conducting the placenta delivery. So mismanagement of third stage of labor leads to maternal death as a result of postpartum hemorrhage. So as a skilled supervision, intellectual observations, and prompt treatment, emergency obstetrical care, we can save so many lives of women during postpartum period. Why women are needed for take care of the baby, newborn baby, and women is needed for the family and for the society. So when, as the government of India and WHO, our safe motherhood initiative is done in a proper manner with emergency obstetrical care and referral services, high risk approach, and proper drill practices or conducting to do the management of postpartum hemorrhage, we can reduce the maternal mortality rate of women due to postpartum hemorrhage. So I hope today you have understood about postpartum hemorrhage. As a summary, today we have seen the one of the obstetrical emergency condition, that is third stage complication, that is known as postpartum hemorrhage. Postpartum hemorrhage, that is any bleeding that takes place in the genital tract more than 500 ml during normal vaginal delivery, that or any time that happens within the puparium, that is 6 weeks after the delivery. This will deleteriously affects the general condition of the women. Then it is known as postpartum hemorrhage. So we have discussed about generally two types of postpartum hemorrhage: primary postpartum hemorrhage and secondary postpartum hemorrhage. In the primary postpartum hemorrhage, two type is there: third stage postpartum hemorrhage and true postpartum hemorrhage. And we have seen about what are the causes of postpartum hemorrhage. You can always remember 4 T's are there. One is tonicity of the uterus, that is atonicity of the uterus. We have discussed so many causes in the atonicity. This you will get repeated questions. What are the causes of atonicity of the uterus? Then next, causes of tissue, that is any tissues, fetal tissues or placental tissues that is present in the placental tissues, or retained blood clots that is present in the uterus, that is known as the tissues. The next one is thrombin because of coagulation factors, and any trauma in the genital genital, that is cervix, vagina, perineum, or in the uterus. And we have seen about the investigation, management, and we have seen about the prevention of postpartum hemorrhage. So this class may be benefited for you, for all the nursing students. Again, I meet you in another live section, so you all can watch our live videos and online classes from our channel rgcsk.et. Thank you.